This is a patient with rhegmatogenous retinal detachment with a history of previous pars-plana vitrectomy for epiretinal membrane. At least this is what we saw in his medical records. He came to us with hand movement visual acuity, total retinal detachment. We noticed some small breaks in the inferior half of the retina during the pre-op consultations, and now we are performing 25 gauge vitrectomy for this retinal detachment. We perform a bit of core vitrectomy so far, and then we injected triamcinolone in order to visualize the posterior pole hyaloid, and then membrane dual blue, and we start to try to detach the internal limiting membrane, but we are using for that the 25 gauge ILM forceps from Alcon. And we notice that we can quite easily grasp the membrane, a sort of membrane which is in front of the detached macula, and we try very easily and carefully to detach it. We don't want to pull too much because we don't want to create any new breaks in the retina. Although the central part looks quite tough and rigid, but you can also create some breaks in the peripheral retina, and you don't want that to happen, of course. What we detached so far looks more like a remnant hyaloid. We detach it partially, we continue, and again with very soft maneuvers, we detach quite a large part of something that it is almost for sure remnant of the posterior hyaloid. So in the previous vitrectomy, the previous surgeon didn't detach almost at all the posterior hyaloid. We stain once again the posterior pole with membrane dual blue because we want to be sure that the internal limiting membrane is gone or not. Most probably it is there, and indeed it is confirmed that the internal limiting membrane is there. We perform the technique pinch and pull, and very easily but with a lot of attention, we managed to detach and to peel the ILM on a quite large surface between the vascular arcades and even a bit more than that. So the peeling was quite a bit larger than the arcades because we want to be sure that we eliminate all the fibrotic area in the posterior pole. At this point now we inject the heavy liquid, perfluorocarbon, and we continue the surgery as a more or less standard vitrectomy for retinal detachment with vitrectomy in the periphery, the shaving on all quadrants, 360 degrees, from the PFCL level up to the anterior part, up to the ora serrata, with attention also for the anterior hyaloid, and also for observing all the possible breaks in the periphery. We noticed initially 4 breaks that we already marked with diathermy, which is not shown in the video. Then we elevated more the PFCL bubble level and put endolaser around those breaks. A bit of OVD, of methylcellulose in the anterior chamber, because this patient had also a cataract surgery performed by the previous surgeon with posterior capsule rupture, and we don't want to have communication between the anterior and posterior segment. And then the usual surgery, fluid air exchange, silicone air injection after PFCL aspiration, checking the IOP at the end of the surgery, and this is the surgery. Thank you.